عليكم. This is an updated evidence on laryngopharyngeal reflux for ENT trainees and students. This is part 1. Part 2 with the MCQ questions will follow next. The backflow of the stomach contents into the esophagus, the gastroesophageal reflux, occurs in most people. It is so common that it is considered a normal physiological phenomenon, so long as it occurs within certain limits. It occurs mostly after meals and in bed in the supine position. It has short episodes of reflux, does not normally cause any symptoms, and does not cause damage to the esophageal mucosa. So long as the esophageal mucosa is not exposed to the acid in the reflux for more than 5% of the 24 hours period, and that the reflux remains inside the esophagus, not beyond, then it can be considered a normal physiological gastroesophageal reflux. The esophagus has certain properties and mechanisms that can physically remove and chemically neutralize the refluxed bolus. When the gastroesophageal reflux starts to cause symptoms to the patient or signs of inflammation or erosion in the esophagus, then it is termed gastroesophageal reflux disease. The tissue damage is thought to be acid-mediated due to the exposure of the esophageal mucosa to the acid in the reflux material. It's still so common to the extent that 20% of the adult population, normal adult population, has reflux symptoms for at least once a week. Half of these number, 10% of the adult population, can experience these symptoms on daily basis. And 10% of patients in the in the ENT outpatient clinic has one form or the other of several diseases related to such a reflux. When the reflux reaches the larynx and the pharynx, and it's termed laryngopharyngeal reflux, it can be demonstrated in up to between 10 and 30% of asymptomatic normal adults. And about more than 50% of the patients who present with hoarseness can have reflux into the pharynx, and about 40% of patients who present with chronic cough in the outpatient clinic can also have reflux in the larynx or the pharynx. What is the pathogenesis of the gastroesophageal reflux disease? It's usually a combination of different factors. A defective lower esophageal sphincter is a primary factor, plus one or more of the contributory factors. A defective lower esophageal sphincter can be either due to impairment of the resting tonic contraction of the lower esophageal sphincter, the tonic contraction that keeps the sphincter closed except when it receives a peristaltic wave with a bolus from the esophagus. If this resting lower esophageal sphincter is impaired, then this can give a form of severe gastroesophageal reflux disease, and this can be prolonged exposure of acid to the esophageal mucosa. But it can happen like transient impairment in the lower esophageal sphincter, only brief episodes of reflux. This transient but inappropriate relaxation of the lower esophageal sphincter can happen in the absence of peristalsis and are referred to as transient lower esophageal sphincter relaxation. This transient lower esophageal sphincter relaxation can last for anything between 10 and 60 seconds and can allow the escape of some of the stomach contents into the esophagus. It can also have a relaxation of the not only the sphincter but also the crura of the diaphragm that supports the tonic contraction of the sphincter. The transient relaxation is mediated by a vagal reflex, and it is one of the primary causes for gastroesophageal reflux, and it is the primary cause in normal individuals. The contributory factors are numerous, including things like obesity that increases the intra-abdominal pressure and also affects the integrity of the sphincter, hiatus hernia that affects the integrity of the sphincter, diabetes mellitus that type 2, and diabetes would cause gastroparesis with accumulation of food in the stomach and increase of the gastric pressure and increase the chances of a reflux. It can be due to a connective tissue disorder that can either affect the motility of the esophagus or the integrity of the valve, or reduce the secretions of the esophagus that protects it from acid exposure. Things like scleroderma, rheumatic disorder, Jogren syndrome, several mixed connective tissue type, including the Zika syndrome. And of course, diet containing things like chocolate, caffeine or alcohol, peppermint, and spicy food can all increase the acid content of the stomach and can also reduce the lower esophageal sphincter tonicity. And some medications, including non-steroidal anti-inflammatory drugs, opioids, and anticholinergics. When laryngopharyngeal reflux occurs, the pH of the pharynx decreases dramatically. The mucosa of the larynx and the pharynx, unlike the esophageal mucosa, are not well protected against the effects of the reflux. They are not rinsed with saliva normally, so small amounts of the reflux are capable of inducing injury to the respiratory epithelium in the larynx, for example. The laryngeal mucosa is either delicate squamous epithelium over the vocal folds or a respiratory type of epithelium in the subglottis and the supraglottis, both of which are far less resilient than the esophageal mucosa in resisting the effects of the reflux. The refluxate is neither removed by peristalsis nor neutralized by bicarbonate like in the esophageal secretions. Tissue damage in laryngopharyngeal reflux is induced by activated pepsine, sometimes by intracellular inactivated pepsine as well, in contrast to the damage in gastroesophageal reflux, which is acid-induced. Also, the damage in the larynx and the pharynx can happen very rapidly following exposure to the acid, and episodes as brief as 30 seconds repeated 3 times per week can induce damage in the larynx, as opposed to the esophagus, which can withstand reflux, physiological gastroesophageal reflux, so that as long as it does not exceed 5% of the duration of a 24 hours duration. The reflux material, the refluxate, can take the liquid form or take the aerosol form. The aerosol form has been detected deep in the bronchi or in the middle ear, and also in the exhaled breath of patients who have laryngopharyngeal reflux. In the liquid form, the acid content would have a higher concentration, both of the acid and the pepsin, but in the aerosol form, the refluxate could go further and injure other parts further away from the larynx and the pharynx, like deep in the bronchi or in the middle ears, for example. Although gastroesophageal reflux disease and laryngopharyngeal reflux share some common pathological and clinical features, there are also some differences between the two conditions. In gastroesophageal reflux disease, the main problem is esophageal mucosal irritation, esophagitis, and erosion, and the main symptom is heartburn. This is rarely present in laryngopharyngeal reflux. In GORD, the main problems would happen at bedtime in the supine position, whereas in laryngopharyngeal reflux, the main symptoms would be during the day and in the upright position. There is usually some abnormal esophageal motility disorders in GORD associated with prolonged esophageal acid exposure. The acid exposure is very brief in laryngopharyngeal reflux, and that has intermittent episodes of the reflux. The main dysfunction in GORD is in the lower esophageal sphincter. The main problem in laryngopharyngeal reflux is a dysfunction of the upper esophageal sphincter. You can have some throat symptoms in GORD if the two conditions coexist together, but throat symptoms are the main symptoms in laryngopharyngeal reflux and are basically due to damage or injury to the laryngopharyngeal epithelium. Given the diverse and non-specific nature of the LPR symptoms and signs, establishing the diagnosis should be based on a combination rather than just a single entity of these. For the symptoms, the patient's symptoms, you need a validated symptoms scoring system like the reflux symptom index or the reflux symptom score. And for the findings, the physical findings, you would need also a validated scoring system, either the reflux finding score or the reflux sign assessment. And investigations, the gold standard investigation for the diagnosis of LPR is the 24 hours monitoring of pharyngeal and esophageal pH and intraluminal impedance, or oropharyngeal pH monitoring, or detection of pepsin in the saliva, or transnasal oesophagostomy, and other investigations including esophageal manometry, for example. Or you can use a composite scoring index, a pre-made index formed out of these elements, and or an empiric treatment trial to establish the diagnosis of LPR. One such validated symptom scheme is the Reflux Symptom Index, the RSI. This is a 9 items questionnaire filled up by patients. It aims at quantifying the severity of the problems on a grade from 0, where there is no problem at all, to 5, where there's a maximum possible severity of these 9 items, giving up a maximum score of 45 points. These 9 items include problems in the voice, clearing the throat, excess mucus in the throat or postnasal drip, difficulty in swallowing food, liquids or pills, coughing up after lying down or after meals, breathing difficulties or choking episodes, troublesome or annoying cough, and globus sensation, and finally either heartburn or chest pain or indigestion or a sense of stomach acid coming up. So out of the maximum of 45 points, a 0 score would mean that there is no problem. Anything more than 10 may indicate a problem. 13 is the cut-off point for positive suggestion of LPR. 20 would suggest a moderate LPR, and 30 a severe LPR. But 13 points would be a positive score for the reflux symptoms index. It should be used at every consultation, the initial and the follow-up consultations. It's fairly sensitive, but has limited specificity. This is, of course, because other conditions of laryngeal inflammations, like viral inflammations or smoking, for example, can produce a high score as well. Single symptoms like having a globus sensation would not produce a high RSI score, so you need to have several of the 9 items symptoms. On the drawback side, it considers only the severity and not the frequency of the patient's symptoms, and it not including some prevalent LPR symptoms like throat pain, odynophagia, halitosis, regurgitation, nausea, and burps. But still useful at documenting symptoms as a baseline and documenting any changes after treatment. Dysphonia is the most common LPR complaint. It is of a fluctuating type and is often associated with voice fatigue, sometimes also voice breaks, mimicking spasmodic dysphonia. The first indication of laryngopharyngeal reflux on stroboscopy, for example, would be a reduction in the vibratory amplitude and the mucosal wave. But this is also shared by all other diseases causing laryngeal edema, like any inflammations or allergies. There may be also an open phase predominance in the glottal cycle with sluggishness of the mucosal wave propagation. Laryngopharyngeal reflux can also be associated with laryngospasm, episodes of sudden adduction of the vocal folds, frequently after heavy meals or exercise. These are triggered by either sensory receptors in the larynx stimulated by the reflux, or a vaguely mediated responses from the distal esophagus. These laryngospasms can sometimes also be associated with bronchospasm. Although there is no single sign that appears to be pathognomonic or diagnostic for LPR, there are at least 6 different laryngeal findings that are commonly associated with LPR. So in symptomatic patients who have these signs, it's more than likely that they have LPR. None of them have 100% sensitivity or close to it or even specificity, but combining some or all of them together would increase the accuracy in detecting LPR. For example, in symptomatic patients who already have symptoms of LPR, if they present with a pseudosulcus, like a subglottic edema, the predictive value is in the area of almost 90% that they have LPR positive. If you see arytenoid vocal process granulomas, for example, there is more than 2/3 of patients who have this would have LPR as well. If there is idiopathic subglottic or posterior glottic stenosis, then the chances are also quite high, almost 90%, that they have laryngopharyngeal reflux. Rhinx edema is also associated with a high degree of LPR. Posterior hypertrophy of the interarytenoid area in here, the interarytenoid pachydermia or hypertrophy or edema or congestion, is also a very common feature in LPR patients, and paradoxical vocal fold movements or spasmodic dysphonia is another sign. Based on these findings, Bilavsky in 2001 proposed the reflux finding score, the RFS, which is a validated scoring system for laryngeal endoscopic findings in patients with suspected LPR. If the patient has a pseudosulcus or subglottic edema, if it's present, then this will give him 2 points. If the laryngeal ventricle is obliterated, this would also give either 2 for partial or 4 for complete. If there is erythema or hypertrophy of the glottis, only over the arytenoids would be 2, and diffuse over the whole glottis would be 4. If there is vocal fold edema with different grades, or diffuse laryngeal edema with different grades. If there is posterior commissure hypertrophy or interarytenoid pachydermia, like in here, with different grades, you'll take from 1 to 4. If there is a granuloma over the arytenoids, for example, or elsewhere in the larynx, and if there is any thick mucus, this would give the reflux finding score. Out of a maximum of 26 points, anything more than 7 would strongly suggest the presence of LPR, because 95% of patients who have LPR proven by pH and impedance monitoring would score more than 7 with the reflux finding score. The controls would have an average score of only 5. These laryngoscopic findings are not pathognomonic, but they are very suggestive. They should not be used alone to establish a diagnosis, but also in combination of symptom score or other investigations. We move next to the investigations for laryngopharyngeal reflux, starting with the 24 hours pH monitoring. You would see this chart, the pH level, intraluminal pH, during a 24 hours period by sensors placed in the pharynx or the esophagus. On the upper traces, you could see when is the patient, for example, asleep in here, and when is the patient feeling symptoms, and when is he taking meals. You would see that the pH line dips quite significantly below the pH 4 level during the daytime. The dipping sort of stops during the night time. This is the period the patient has been in supine position, and you could see that his pH level has not dropped below the line of pH 4. So this is an example of daytime acid reflux. In contrast, you could see that this period was marked by the patient as sleeping, and during this period you could see that the pH fluctuations had dipped below the pH 4 level quite significantly. Most of the night sleep he had a pH less than 4. This is an example of severe nighttime reflux. In addition, we can also monitor the intraluminal Pharyngo-Oesophageal lumen impedance during a 24 hours period. Impedance would tell us a few more things. The impedance, for example, baseline in here in this sensor would usually be around a level of 3000 ohms. When the impedance dips substantially below the baseline, it usually indicates a mucosal injury from reflux when it dips below 2000 ohms, for example. Also, impedance would tell us a few things about the character of the bolus itself. So when the impedance increases sharply, like in here, more than 5000 ohms, for example, this usually indicates gas in the the esophagus or the pharynx. When it dips below the baseline, like in here, this would mean that there is a liquid bolus passing through the lumen at this level. You have impedance level at impedance monitoring at different levels in the pharynx and different levels in the esophagus. So we could also monitor the progress of the bolus at different levels of the pharynx and the esophagus. And from the timing of the bolus passing, you could tell whether the bolus is going from the pharynx downwards, like in swallowing, or the bolus is coming from the lower esophagus upwards to the pharynx, like in reflux. In this chart, you could see the monitoring the pH level in the lower segment of the chart with impedance monitoring at different levels in the pharynx and in the lower esophageal sphincter, and above the lower esophageal sphincter by 5 centimeters and below the upper esophageal sphincter. So at various levels we are monitoring the impedance, and this is the pH level 5 centimeters above the lower esophageal segment. And you could see this dip in the pH level, which is weakly acidic because it's not proceeded beyond the line of pH 4, and it's liquid because there is a dip in the impedance level, which started here and progressed upwards until the upper part of the esophagus and the lower part of the pharynx. So this is a reflux of a weakly acidic fluid. Another technique for monitoring the pH level in patients suspected of having LPR is this, the oropharyngeal pH testing, PHM. It's less expensive and is better tolerated by the patients because a tiny probe would be passed from the nose to the level of the uvula, just at the level of the soft palate. It's tiny, it's about 2 millimeters, and it would measure 24 hours pH changes at this level. It has a different set of norms at this level in the oropharynx rather than in the hypopharynx or the esophagus, a different set of measures for normals like the number of the events and its duration. The normal levels would be that the events of pH less than 4 would be very few, less than 2 or 3 events per 24 hours, whereas if the pH measured at less than 5 could reach up to 100 events in a day, and less than 6 it could be even higher at 128 something. Remember that pepsin can still be active at pHs around 5.5 to 6 or so. So even though these are not very acidic environment, the pepsin and its injurious effect on the mucosa of the pharynx and the larynx may still be active at such pH levels. The problem with the oropharyngeal pH testing is that it is not very sensitive, so it can miss easily some reflux episodes that can be picked up by the intraluminal pharyngeal and esophageal impedance and pH monitor. And there is still some controversies about its ability to truly diagnose LPR because of that. And these are examples from charts for measuring oropharyngeal pH. When there is no laryngopharyngeal reflux, the pH level remains above the 6.5 level up to 8 level in here with no dips. But you can see in this chart here that there are some significant dips in the pH level, usually following meals that are marked in there, and also during sleep that is marked in here. The pH level dips quite significantly, and if it dips below 5.5 in the upright position or below pH 5 in the supine position, then this could be marked as acidic reflux. On the other hand, if the pH is elevated a little bit above the level of pH 8, it marks an alkaline laryngopharyngeal reflux. And finally, there is a subset of patients who have silent reflux. These are patients who present with laryngopharyngeal reflux symptoms and sign in the absence of the classic gastroesophageal reflux disease. Rather, they would have physiological gastroesophageal reflux with no signs of inflammation or erosion in the esophagus and no gastroesophageal reflux disease symptoms. So this subset of patients would have only laryngopharyngeal reflux symptoms in the absence of any classic gastroesophageal reflux disease symptoms. These patients will be labeled as having a silent reflux. Pepsin in the refluxate of patients with LPR as the primary offending factor in causing injury to the laryngeal and pharyngeal mucosa, and detecting pepsin in the saliva of patients suspected of having LPR would establish the diagnosis. The technique is rapid and it's non-invasive and it's not expensive. It entails the patient providing several saliva samples by spitting into containers small containers containing citric acid and using test strips to test for the presence of pepsin. The test is not very sensitive. That's why you have to provide several samples in order to increase the chance of detecting pepsin in from a single patient. Sensitivity could be as low as less than 30%. The detection of pepsin would depend on several factors, including the concentration of the pepsin in the refluxate, the time of the saliva collection, the number of the samples provided by the patient, the more the better, the technique used for measuring it, and also in relation to the patient's eating just before the saliva sample was produced. And then flexible transnasal oesophageal, which should not be used in every patient of suspected LPR, but used if the patient does not respond to a trial of medical treatment for 3 months, or if the patient has any sort of alarm features, like if the patient also complains of dysphagia, hematemesis, unexplained weight loss, or a family history of upper GI cancer. There is a consensus that the endoscopy should cover these points in systemic way. Check for insufficiency of the upper and lower esophageal sphincters, if there is any hiatus hernia or gapping of the cardiac sphincter, any visible reflux, any signs of peptic esophagitis, any signs of Barrett's esophagus or ectopic gastric mucosa. This will be found in a certain percentage of patients, much less than those who have GORD, for example, but the presence should be noted and monitored. Another approach to establishing a diagnosis of LPR is combining scores from different systems, different subjective and objective systems. If we combine scores from all 3 or 4 different systems, we increase the accuracy in detecting LPR. The Horvath scoring index is one such scheme. It combines results of the reflux symptoms index, reflux finding scores, oropharyngeal pH-metry, and the transnasal oesophageal. These several tests had different specificity and sensitivity. Combining them together would help in better identification of LPR. The results for the Horvath scoring index, if it is less than 1, 0 or 1, this would be a normal subject with non-existing LPR. Between 2 and 3, like in here, this would be a non-severe LPR, and 4 and 5 would be indicative of a severe LPR. How do we obtain the score for the Horvath index? We combine the results of these 4 different tests. The first is the symptoms index, and if it is positive, then the patient will get 1 point in the Horvath scoring, and the reflux finding score, if it is again positive, then the patient would have also 1 single point. And then the also oropharyngeal pH-metry, and now if the reflux is severe, patient will get 2 points, but if it is either alkaline or neutral or mild or moderate, he would get only 1 point, and if there is no reflux, he would get nothing. And finally, transnasal oesophageal, if there are findings indicative of a pathology, he will get 1. And we add all these points together, and if it is between 0 and 1, then there is no evidence for laryngopharyngeal reflux. 2 to 3, this would indicate moderate or mild, or even alkaline reflux, and 4 to 5 would tell that this patient has severe reflux. Another pragmatic approach for establishing the diagnosis of LPR is monitoring the response to empiric therapeutic trial, giving all suspected patients of LPR an empirical treatment covering acidic and weakly acidic and non-acidic LPR, and monitoring the response to this. And this would entail giving the treatment to too many patients unnecessary, and of course many of these patients may experience unnecessary risk of adverse events, and there are increased costs for both the patients and the healthcare system. It remains a widely used approach in establishing the diagnosis of LPR, particularly when there is no availability for intraluminal pH and impedance monitoring, the gold standard for establishing the LPR diagnosis, or other methods. But the issues surrounding widespread use of medications in patients with only suspected symptoms or signs should be considered. The first step in the management that should be applied to all patients: modifications to the diet and the lifestyle of the patients. This includes reducing the stomach acid production by avoiding things like spices, pickles, mature cheeses, salt, sugar, mint, caffeine, alcohol, and of course smoking. Also reducing the intra-abdominal pressure by reducing body weight, avoiding carbonated drinks and tight clothes, reducing gastroesophageal reflux itself by elevating the head of the bed, and avoiding things like vigorous exercise or food within 3 hours of sleep time or exercise, and prevent lower esophageal sphincter incompetence by avoiding alcohol, tobacco, chocolates, and high fatty food, and reducing the stomach emptying time by avoiding fatty food. And the cornerstone in the medications would be proton pump inhibitors. Proton pump inhibitors act for only 12 to 14 hours, so treatment in the case of LPR should be by twice daily doses of PPI that would give a full 24 hours protection. Things like, for example, omeprazole, either 10 or 20 milligrams twice daily, or pantoprazole, again twice daily dosages. It should be given at least 30 minutes before meals and should be given for a period of at least 3 months, sometimes 6, and sometimes even more if necessary. The proton pump inhibitors would reduce the volume of the acid reflux, but the non-acid reflux may still occur. H2 receptor antagonists have mainly been superseded by proton pump inhibitors because proton pump inhibitors have a more potent action in blocking gastric acid secretion. But they may still have a role in patients who experience nocturnal acid breakthrough despite having twice daily doses of proton pump inhibitors. Adding H2 receptor antagonist at night time would help with the breakthrough reflux. Antacids have a proven, although a weak, effect in controlling symptoms of LPR. Randomized controlled trials show that they actually have better results in reducing symptoms and acid reflux more than a placebo. They are fairly safe drugs, but the aluminum-containing antacids should not be used in patients who have renal disease, and the calcium-containing antacids should not be used in patients who have hypercalcemia. Other medications are required in addition to the anti-acid suppressants in the form of, for example, alginate reflux suppressants. Alginates have been shown to be effective in the management of LPR symptoms, either taken alone or in combination with PPIs and probably H2 receptors antagonists as well. They form a mechanical barrier between the stomach contents and the esophagus. Thereby, they prevent the reflux from reaching the esophagus and can manage or help in managing things like non-acidic or weakly acidic or mixed acidic reflux. They can also be used for breakthrough symptoms if the patient complains from things like cough or globus, and can be used just before certain activities that can cause reflux, such as vigorous exercise or even singing. But the usual is that alginate would be given after each meal and last thing at night. Other agents, like mucosal protective agents, Sucralfate, would act by blocking the diffusion of the gastric acid and the pepsin through the mucosa of the esophagus or the pharynx, and can even stimulate mucosal growth factors. It's a safe drug with a good efficacy in controlling GORD and sometimes LPR symptoms as well. It has also the potential of improving mucosal healing. Because it is safe, it's the option of choice for symptomatic management in pregnancy. Another medication is GABA B receptor antagonist like baclofen, which acts by reducing the number of reflux episodes, whether these reflux episodes are acidic, non-acidic, or even alkaline. However, they are particularly useful, of course, in the control of alkaline and weakly acidic episodes in combination with proton pump inhibitors, which would control the acidic reflux episodes. In addition to decreasing the number of reflux events, it also is helpful in reducing the esophageal acid exposure time and the reflux-related symptoms, both as monotherapy for maybe 2 to 4 weeks or in addition to proton pump inhibitors. The problem with baclofen is that it has a short half-life and poor tolerability. There are certain central nervous system and abdominal side effects like dizziness, like drowsiness, nausea, vomiting, or diarrhea. The recommended dosage is 5 to 10 milligrams 3 times per day, but with close monitoring of neurological and abdominal side effects. Among all of the GABA-B receptor agonists, baclofen is the only effective one for the recurrent patients with GORD or with LPR symptoms. Prokinetic agents were believed to be helpful in the management of GORD symptoms, particularly if dysmotility is an issue. It acts not only by improving gastric emptying, but also by increasing the lower esophageal sphincter pressure and improving esophageal clearance. However, a recent meta-analysis found no evidence of any value for adding prokinetic agents to proton pump inhibitors in the symptomatic control of GORD symptoms or LPR patients. So generally, it's not very useful in the management of LPR patients. The majority of LPR patients who are on the adequate proton pump inhibitors and H2 receptors antagonists, plus alginate, probably with antacids, would respond to the treatment management after adjusting their diet and their lifestyle. A small proportion of the patient may require some long-term treatment, more than 6 months, but majority of them would need a step down. If patients don't respond to such medical treatment, or if they require long-term high doses of proton pump inhibitors to control their symptoms, they either need specific extra medications or consideration of surgery. For those patients who respond well to the medical treatment within 6 months, they should not stop their proton pump inhibitors dose abruptly because rebound symptoms are common, and stopping the therapy would initiate such rebound symptoms. For example, if the patient was on pantoprazole 40 milligrams twice daily, and then for 2 months he would need to halve the dose to pantoprazole 20 milligrams for a further 2-month period, and finally pantoprazole 20 milligrams once daily for a final 2-month period. Then he would stop all the pantoprazole and would continue with some alginate and potassium bicarbonate 5 milliliters 3 times a day after meals. And he would take 10 milliliter of the alginate with the antacids at night for about 2 weeks to help in reducing his symptoms. Also may be advisable to supply the patient with some PPIs for ad hoc use, for example, before going out for a meal in a restaurant or after certain vigorous exercise. Most patients don't need to be on long-term proton pump inhibitors. Only a small number would need to remain of some maintenance therapy. But alginate and antacid and dietary advice are more suitable for the long-term measures in the treatment of responders, of patients who responded well to the triple therapy. If the patients continue to be non-responding to all medical treatments, or if the patients require long-term high doses of proton pump inhibitors to control their symptoms, then surgery should be considered. The main aim of surgery is to increase the competence of the lower esophageal sphincter and decrease any diathesis in the crury of the diaphragm. It involves one of several forms of laparoscopic fundoplication, but also new operations described includes endoscopic, transoral, incisionless fundoplication, or the insertion of magnetic sphincter augmentation, or radiofrequency therapy to the lower esophageal sphincter. By this, we come to the end of this presentation on laryngopharyngeal reflux for ENT trainees and students. Part 2 with MCQ questions will follow next. Assalamu alaikum.